You're welcome. This is Dr. Anthony Mahoba. I'm a physician at St. Francis Hospital in Zambia and currently pursuing my postgraduate diploma in endocrinology by the University of South Wales. I want to share with you this video how to approach a patient who comes to your clinic or to your office with a thyroid nodule and how to go through a stepwise approach to exclude the possibility of cancer in such a patient. Thyroid nodules are common, so at the end of this presentation, what do we expect to learn? We want to be able to recognize a thyroid nodule and then ask yourself the question, which patient's thyroid nodule is likely to be cancerous? And then how do I assess this patient for the possibility of a cancer in their nodule? And who and where should I refer such a patient if I'm in a center that does not have the capacity to treat these patients? Thyroid nodules are common and they will typically appear like what we can see in these two patients whose pictures I've shared here, anonymous patients. So we can see these are patients who come with swellings in the lower part of their front of their neck. They could have come to their attention through a friend or a family member, or they themselves, they may have experienced some symptoms, or maybe they were looking in a mirror and then they saw something in their neck and it prompts them to come to you to assess it. So thyroid nodules are common. It's estimated that there is a 5-10% lifetime risk of developing a thyroid nodule, and this risk is much higher in the females, where it's about 5%, and in the males a bit less at about 1%. So definitely in your clinical practice, you will see these patients. And also as a patient, when you find this thing, you may be concerned. Could it be a cancer or maybe something that is benign or non-cancerous? So which patient should I consider that could be having a thyroid cancer? So the first patient is a male patient. Like you've seen, these nodules are less in the males, but when they happen, then you worry, could it be possible that it's cancerous? Then the patient's age. If a patient is less than 20 years, so these are young people or people who are above 60 years of age, these ones take them more seriously. Or people who could have lived near a nuclear reactor accident. If the person resided in a place which had such an accident, then what about it? Then people had the radiation to their neck, head, or upper part of the chest, especially in their childhood. Then people who will tell you that in my family, or I personally have had a history of maybe a thyroid cancer in the past, or I have had another cancer like breast or colon cancer. These are patients who could be at risk. Or in their family, they have this genetic disorder that we call multiple endocrine neoplasia that has a constellation of various conditions, of which one of them is what we call familial medullary thyroid cancer. These are patients that could be at risk of cancer as well. Then speed of growth. I recently had a patient who told me they had a nodule, or what they call a goiter, for about 7 years. But for the past 1 year, it has grown so much that they attempted to come to see the doctor, yet they had had it for about 7 years and they were not concerned. So this is a patient whom you should assess quite seriously. And then a patient may tell you over the past few months or weeks they have experienced a hoarseness of their voice. This is a nodule that could most likely be infiltrating and affecting their laryngeal nerve. Or they tell you they cannot swallow very well, or even their breathing has a problem. These are patients that could be having a cancer in their thyroid. And then when you see this patient, so you should assess them. And your assessment, of course, starts with taking history that we have looked at, looking at the risk factors. Then you should also examine them. Like in good clinical practice, you should examine these patients completely, from the general exam to everything. But in the general exam, be aware of the fact that these patients could be having what we call a toxic nodule. This is a nodule that's secreting a lot of hormones. So they may come feature suggestive of thyrotoxicosis. They may have lid lag, they may have protruding eyes, they may be sweaty, they may have changes in their nails and other things. So when you suspect this and you pick them up, these are patients who could be having a toxic goiter, whose assessment and treatment you should be able to pursue. Then you go on to palpate, like I've shown you here in the picture. When you go to palpate, find out where is this nodule. Is it in the left, the right, in the isthmus? Is it one nodule or there are many? Be able to take the dimensions of this nodule. Nodules that are likely to be bigger than 3 centimeters are quite suspicious. Then feel for the consistency of this nodule. Is it a hard nodule? Does it easily move or it is immobile? Does it feel like it has infiltrated in the surrounding structures? These are high risk features when you find them. Then also check the neck delicately in a dedicated fashion for the presence of lymph nodes, especially the supraclavicular and any cervical lymph node that is around this patient's nodule. These are features that could be suggestive of a cancer. So after you've done this and the rest of the general physical exam, after you've been directed by your history, Then the next investigation that is important is to do a thyroid stimulating hormone. This is a hormone that is produced by the pituitary gland that controls the secretion of hormones in the thyroid gland. So if you find that it is low, these are patients that most likely have a toxic nodule that you should assess and treat. But for those with a normal or an elevated TSH, these are patients that should evaluate further. And next important investigation that you should do is the ultrasound scan of their thyroid nodule. There are features on ultrasound scan that are very highly suggestive of a possibility of a cancer. One is the size of the nodule. If you find big nodules like the ones you can see on the screen here, these are big nodules. A nodule that measures 3 centimeters and greater in diameter is quite a big nodule. And then there are nodules whose margins are indistinct. You can't see, like in figure B there that you can see. The nodule's upper border is not very distinct. So these are suspicious nodules. Then there are nodules that are taller than wide, like you can see in image C. It is taller than wide. So this is also a high risk feature. Then calcifications, like you can see in figure D. And then local invasion during ultrasound can tell it has infiltrated these other neighboring structures. So nodules that have these suspicious features, you should follow up and do a thyroid fine needle aspiration cut or cytology. So this is with the help of the needle. It can be done blindly or with the help of ultrasound scan, especially if they are quite small. Then the fluid that is got from this is assessed through what we call cytology. And cytology is reported according to either the Bethsaida system or the British system. Normally, the features or the findings on cytology will tell you what to do. If it is non-diagnostic, most likely you need to repeat. But if it is reported as 2, which is benign, then maybe no worry. But if you have a reporting from 3 down to malignant according to Bethsaida, or Thai 3 down Thai 5 according to the British system, these are nodules that possibly need to be evaluated further and possibly intervention will be required. Because the higher the grading, the higher the risk of malignancy, like we can see. Of course, if they report it as overtly malignant, that is malignant. So it should be taken as so. But from Thai 3 to 5, these are patients that should be evaluated more seriously for the possibility of a cancer. So you may be in a center that doesn't have all these facilities. Or you may be in a center where you only take the history and you find these suspicious features in history and physical exam. Or you get an ultrasound report and you worry that this is suspicious. So these are patients that should be able to refer. Or you have been able to do the FNAC and the cytology reports, Thai 3 to 5. These are patients that you may want to refer for further evaluation. So where should you refer them? So like here in Uganda, you may find these patients found in a health center 3, 4, or district hospital. These are patients that should be able to refer to a higher facility like the regional referral centers, or we have established cancer centers like the Uganda Cancer Institute. In Zambia Hospital also runs a cancer center. These centers have a multidisciplinary team that should be able to assess these patients further so that they are able to tell whether this nodule indeed is malignant and then advise on the best plan of action. Of course, the treatment approaches that these centers are likely to offer can be a combination of any of these 3. Most likely, most patients will need a surgery, either they remove one lobe or what we call partial thyroidectomy, or they may need a total thyroidectomy depending on the risk of cancer. Some of them may be followed up with radioactive iodine ablation therapy and then subsequently thyroxine suppression therapy. But these are decided by the members of the multidisciplinary team after assessing this patient and discussing this patient. So I hope this was quite useful to you because you'll encounter these patients in your clinical practice and should be able to act as we have shared. Thank you.